Hello, everyone. It's Tyson Moore again here. I am the nurse practitioner here at Children's Mercy Kansas City in pediatric nephrology, mainly dialysis and kidney transplant, and I'm also the ANNA pediatric SPN lead. And I wanted to talk to you guys today about anemia and pediatric chronic kidney disease. Some of the people on here, this may be a refresher. Some of this may be some new information, but I think it's always good to review this to make sure we go over every little reason that our population can have anemia and ways that we treat that. So our objectives today are very simple. We're just going to understand how and when anemia develops in chronic kidney disease, specifically in pediatrics, but it's true for adults as well. Identify some various labs to help us identify the different types of anemia your patient may have. And then I also going to kind of share my perspective or a provider's approach to how I go about diagnosing the different types of anemia and maybe how I might treat each one differently. And then we're going to recognize, just those common medications along with a provider perspective that we commonly use to treat anemia in this population. So the background I wanted to share with you is interesting, but it kind of drives home the point. So data from what we call NAPRTICS, or the North American Pediatric Renal Trials and Collaborative Studies, have demonstrated that there's a prevalence of anemia in our children with chronic kidney disease is about 73% starting at stage CKD3. 87% around stage 4 will have anemia, and then as you obviously progress towards stage 5 or end stage, 93% of those patients are going to have anemia. So as you can see, as the CKD stages progress, so does the prevalence of anemia. The anemia in chronic kidney disease, specifically in children, is associated with substantial morbidity. And I can tell you firsthand that is true because there's an increased risk of cardiovascular disease, decreased quality of life for these patients, and then obviously a decrease in exercise capacity where they can't even walk up a flight of stairs with getting short of breath, or they can't do the normal activities that their peers can do. So when we talk about the cardiovascular disease, we know that anemia has been linked to increasing the risk of developing left ventricular hypertrophy. We detect that using echocardiograms. Our patients usually get them at least annually. Most commonly, they get them, I would say, more like every 6 months, specifically those that have high blood pressure. So anemia is going to cause your LVH on top of high blood pressure, and is very prevalent in children with chronic kidney disease. And the unfortunate thing is we have to do a better job of treating anemia because most of our patients with the cardiovascular disease early on will end up most likely having a decreased life expectancy. And some of those patients I've worked with have actually passed away in their mid-20s from left ventricular hypertrophy that could not be resolved. So that association has been noted not only in children on dialysis, but those among with CKD. So there's different studies looking at that, whether it be the CKID study, which has a big cohort. And these children with anemia can have LVH at stages 2 and 4. So it's not just the end stage population that we need to look out for. We need to look into those patients who have early stages of CKD and make sure that we're treating anemia and high blood pressure accordingly. So though among our adolescents maintained on hemodialysis specifically, there's decreased hemoglobin levels are a strong independent predictor of mortality. And this is from Atkinson and Firth. And this is a really good article if you want to read about anemia in this population. It goes over it head to toe. But it's very scary that, our adolescent population, it's a very good predictor with anemia that they're going to have an increased risk for mortality. So how does anemia develop though? It can be for many different reasons, but anemia can develop beginning around CKD stage 3. Some I've seen in CKD stage 2, but a lot of it starts in chronic kidney disease stage 3, and it's due to the kidney's inability to secrete this hormone called erythropoietin. And that hormone then in response is responding to, as the kidney sensing the blood going through it, it's constantly monitoring the hemoglobin level. And as it senses a decrease in your hemoglobin level, it will start to release this hormone. Well, this hormone, erythropoietin, tells the bone marrow to produce new red blood cells, and it also delays apoptosis, or lysis and destruction, or programmed cell death of the red blood cell. That's really important because the normal lifespan in a healthy child or adult is around 120 days. But in our population, children with chronic kidney disease, their programmed cell death or apoptosis is reduced to about 80 to 90 days. So as you can see, the life span of a red blood cell for a patient with chronic kidney disease is much shorter than the normal patient. The other thing with erythropoietin and all that, it's your body's kind of native system. So if you were to think, if you got in a motor vehicle accident or you got injured and you were bleeding a lot, it's the same thing where your body is trying to protect itself as it's sensing decreased blood going to it, decreased hemoglobin to it. It will release erythropoietin, which unfortunately we have to supplement in this population because they just don't produce enough. Again, there's some articles down here. That's where I got some of this data. These are really good articles if you need some to review the management of anemia in chronic kidney disease with children. But the anemia is not just from that response of the decreased erythropoietin from the kidney, talking to the bones, preventing cell death. We have to also look at dietary restrictions. We put a lot of dietary restrictions on our patients due to maybe they have high potassium levels or high phosphorus levels or high salt levels or sodium levels in the body. And a lot of these patients, specifically the ones that are eating by mouth, they run into challenges because there's only so many things they can eat and they get burnt out really quick. But dietary restrictions do lead to can lead to inadequate oral iron and vitamin intake. So a lot of these patients will need to be on iron replacement, and specifically those on dialysis or later stages of CKD, not on dialysis, may require a renal multivitamin. These multivitamins are very specific to our population. They don't contain the levels that you would buy from a pharmacy or over the counter, because a lot of those are way too high for what our patients can take in vitamin A and other vitamins. The specific renal vitamins are usually called Nephrocap or Dialyvite with zinc. Although the Dialyvite tastes nasty, just letting you know, most patients will complain of that. The multivitamins are very specific B vitamins dosed accordingly for this population compared to your normal renal multivitamin. The multivitamins do not have iron, so you will have to supplement iron, usually in the form of like ferrous sulfate, or patients on hemodialysis will get it via on dialysis IV. Hemodialysis itself can lead to anemia, especially those smaller children who are on frequent treatments. So, the standard is Monday, Wednesday, Friday for most patients, somewhere around 12 hours a week to make sure they're staying healthy. But the littler kids, they can't go that long, especially those that are anuric or don't have any urine. They can't tolerate the volume overload. So they may need to be on 6 days a week, 5 days a week of treatments. Those frequent treatments lead to iron and red blood cell loss in the extracorporeal circuit because we can't give all the blood back. And we know somewhere around 30% of the iron in their blood can be lost just by doing frequent dialysis every day. So don't forget that your patients can become very anemic the more you increase frequency of treatments. Then when you're trying to make med schedules, this can be even more challenging because you're trying to figure out the timings, what's actually likely are they going to be able to take? Because if you make a med schedule where they're taking meds 4 times a day, your compliance with that is going to be poor. Most of the time we try to keep our meds to, twice a day, no more than 3 times a day. But when you're making your med list, you got to look out specifically for your medications that are to treat bone. So when I think of that, I think of calcium carbonate. Those medications bind to iron, and it will essentially you won't get exposed to any iron that you take orally, any oral supplements of iron, that is. So if you take your ferrous sulfate or your iron tablet, and then you take your calcium carbonate at the same time, the likelihood you're going to absorb your iron is poor because the calcium carbonate is going to act like a magnet, just like it does if you're using it for a phosphate binder. It's going to bind to the iron and you're not going to get any absorption, and you're going to keep having iron deficiency anemia. On our little population, again, those specifically the infants and toddler age, you need to be making sure, especially when patients are admitted, that the team is being very judicious on how frequently they're drawing blood. Iatrogenic anemia, or this essentially means anemia caused by the medical team from frequent blood draws. I see this commonly where they're drawing labs and they're really not doing anything with the labs other than it's just set up to draw every day or checking a BMP every day or CBC. A lot of these kids, unless they're in the ICU, don't need blood drawn every day. So when you give frequent blood draws every day, this population will become very anemic too fast. And that, secondly, the point on that is where you got to be judicious, because as you're making them more anemic, you may be the cause why these patients require more blood transfusions, which then only exposes them to more antibodies, making it that much harder to transplant them in the future. A home patient, we've ran into this before, specifically in our adolescent population, where we deal with the compliance of medications. Are they being adherent? Are they taking their oral iron supplements? Are they taking their multivitamin? But the one I really worry about is, are they giving themselves either, Epogen injection or an Aranesp injection? Because we've had patients where things just don't make sense when we look at their labs. The patients swear up and down they're doing it. You have to do a deep dive and never assume. And because I've had one patient where how the family was doing it, we broke it down and told us every little step of how you're doing it. And so the family would have it, the family would help draw it up, and then the kid would go in the bathroom and, quote, give themselves the injection. Well, the kid had finally admitted that, or the adolescent finally admitted that they were squirting the Epogen in the toilet. I've also had the same scenario where the adolescent was injecting the EPO into their mattress or their pillows to hide, that, and they would give the syringe back and say, I gave my shot. So if things don't make sense, sometimes it's adherence. And you kind of have to deep dive, but not like say it in a way where you're going to get the adolescent to become very defensive, but just asking clarifying questions to that population. And then lastly, secondary hyperparathyroidism. As you're treating your bone, so secondary hyperparathyroidism, or elevated parathyroid hormone, which is another morbidity that you will see in later stages of chronic kidney disease, specifically those in end stage. Well, that will lead to an inadequate response to your erythropoietin stimulating agents, or your ESAs. So if you have a really high PTH level, your bones are kind of irritated, because the point of the PTH then will be to go to steal calcium from the bone to help correct the calcium and phosphorus balance in the blood. Well, if you have a high PTH, your bones are already kind of irritated anyways, because they're having more osteoclastic activity and being destroyed. They're not going to respond. The bone marrow is not going to respond as well to your ESA or your erythropoietin stimulating agent. Thus, you may keep having increased doses without seeing response. You really need to get your PTH level under control, meaning at least less than 500, optimally somewhere between 100 to 300, even 400. But when you start getting in the thousands, you really got to get that under control for your ESAs to be effective. These are common symptoms of anemia. These are all basic ones that we've learned. Obviously, you're going to have fatigue, pallor, or pale appearance. You'll be very sleepy and drowsy at times because of the low hemoglobin level in your body. You may even have, if it's low enough, you'll see patients that have tachypnea or shortness of breath, or even tachycardia, such as an increased heart rate. You may have depression and impaired cognition. And you would say, well, that's interesting. How does anemia cause that? It's been linked in previous studies that anemia can lead to depression because the patient is so fatigued and doesn't have any energy to do anything or any desire to do anything. And then obviously, if you're not oxygenating your body appropriately because you have low hemoglobin levels, then it impairs your cognition and how you think, because your brain's not getting the fuel it needs, or the red blood cells carrying that oxygen to the brain. I've had patients also complain sometimes if they get low enough, they may have low blood pressure and they may get dizzy because they don't have enough blood in their body. So they have to be very careful when they're changing positions. They kind of get orthostatic on you. Or again, kind of goes with impaired cognition, but they can even have headaches because they're not getting enough oxygen to their brain. I've had one patient have anemia and actually have kind of a migraine symptom because, again, they're not getting the oxygen they need to the brain. Iron deficiency will also cause pica behavior. I'm not sure if you've seen this. Patients with low iron studies, meaning they have a low serum ferritin, and we'll cover this later, but their transferrin saturation in their blood is not high enough due to many reasons we discussed earlier, and they'll start eating weird stuff. Most common thing you'll hear people do is, oh, they're chomping on ice. They want to eat a lot of ice. They like to crunch on ice. I've had other patients eat baking soda. I've had patients eat drywall. I've had patients eat hair. I've had patients eat paper. So when you start seeing these abnormal behaviors of what they're eating, don't forget about anemia. Obviously, it could just be a behavioral thing, but if you're patient, you might want to check their iron studies, because it could be iron deficiency causing your behavior of these weird eating of weird substances. Again, not to forget it, it was stressed earlier, anemia can lead to left ventricular hypertrophy as seen on an echocardiogram, making sure you're doing your echoes on your patients. So then when we break it down and we look at some labs for anemia, the first thing, the most easiest thing to draw is a CBC or complete blood count. That's going to give you your hematocrit hemoglobin, what's called the mean corpuscular volume or MCV, and then some other ones, which is like the MCHC is kind of the color of the red blood cell. How does it look on color? And then RDW, which is called the red blood cell distribution and width. And those are all fancy things, but it does help us determine what type of anemia the patient may be having. A BMP is helpful as well because uremia can lead to oxidative stress and cause weakening of that red blood cell wall. So if your patient is more uremic, they have a chance of having higher hemolysis risk or apoptosis of the red blood cells. So again, uremia can lead to, as we know before, they already have a decreased red blood cell lifespan. So if your patient is not getting adequate dialysis, they may struggle with more anemia. Your iron panel is also something that should be checked for patients that have anemia. It's kind of like a duh, but sometimes I see it overlooked. That's going to give you, when I say iron panel, it's a slang thing, meaning a few other labs that you'll have to draw, specifically a ferritin, which essentially tells you what is your iron storage, if you think about it that way. So ferritin is your storage in your body that you have of iron, then the iron level in the blood, and then this other one called the total iron binding capacity, or TIBC. The TIBC is kind of your transporter or your open capacity. And how we do it is we do a calculation to tell how well your blood is being saturated with iron. And that's called, what we shorthand is called TSAT or TSAT, TSAT. And that's just the transferrin iron saturation in the blood. And how you do that is you take your iron level in your blood and you divide it by your total iron binding capacity. And that will give you your TSAT or your transferrin saturation in the blood. You would like that at least, as you'll see later, greater than probably 20-25%, to know that you're doing a good job giving the body enough iron in the blood. Just having a high ferritin alone is not good enough, and we'll explain why later. Other labs, if things aren't making sense, you may check reticulocyte count. So reticulocytes are the baby blood cells. So when the epigen or the erythropoietin hormone goes to the bone marrow and it tells the bone, hey, make some more red blood cells, it's going to say, great. It's going to make all these little baby blood cells. Those are all called reticulocytes. What's good to see, why do you check that? It tells you if you're having an adequate response to your erythropoietin stimulating agent, that you have the right enough dose on board to stimulate the bone marrow to make more red blood cells. If your reticulocyte is low, then you need more ESAs or erythropoietin, like epigen or Aranesp. You need to increase your dose because your bone marrow is not making enough red blood cells. LDH can be drawn if you think the patient is having hemolysis. So if there's any reason that's not making sense, you're like, I don't understand where are these red blood cells going. We can't find any other reasons for anemia. And LDH will tell you if it's high that the patient's having hemolysis. You also will want to think about drawing a CRP. A CRP is a sign of inflammation. It's like a chain reactive protein, but if it's greater than, usually I've seen difference of opinions, but like less than 0.5 is considered normal. If they're around 1, you could say, what do I make of it? It's not really anything. But if they have a high level, like in the 20s, 30s at times, something's going on, whether it's infectious or maybe a rheumatologic disorder causing inflammation. If you have inflammation, your body won't respond to any of your ESAs as well. And then what will happen is your body will go into conservative mode, and it will take any iron in your body because it thinks something bad is going on, and it will store it. So your ferritin level will go really high, but your actual saturation in your blood can drop because your body's going into conservative mode, trying to conserve your iron, thinking something's going on, I need to preserve iron. If you're also looking for hemolysis, you can have the pathologist do what's called a peripheral smear. Essentially, what the pathologist will do is they literally just kind of smear the blood on a slide and give you a description of what the red blood cells will look like. If you're having hemolysis, you'll see these little things called schistocytes, meaning there's the little fragments, they kind of look like a crescent shape of a moon. That will show you signs of hemolysis, or it'll give you the description if the cells are really big or really small, and what color they are. So it's really kind of a more descriptive analysis of what the blood looks like on a slide. And end stage, I can't comment for this chronic kidney disease population as much, but specifically in chronic or end stage kidney disease, you want to be checking like copper, specifically those that are on hemodialysis. You want to check a carnitine level, folate because of dietary restrictions or not taking the multivitamin, and then a vitamin B12, sometimes B6. So let's move on now that we've kind of covered why these patients have anemia, likely causes of anemia, what kind of labs you think about drawing when you're working a patient up for anemia, and then let's go through kind of the provider thought process. So anemia is usually considered when the hemoglobin is less than 10. That's kind of standard for at least CKD stage 5. Most commonly, it can be seen when you're dealing with insurance companies and you're trying to get things approved. They'll want to make sure the hemoglobin level, even at CKD stage 4, is less than 10 to consider them required or anemic enough to require medications. So anytime a patient's hemoglobin is less than 10, they're anemic for this population. Iron deficiency anemia, when I think about that, when I look at the labs, and we talked about the ones we draw, so if your ferritin is less than 150, or your TSAT is less than 20, and or those two things together, that'll be considered iron deficiency anemia. And those patients would usually need an iron supplementation. And what you'll see on the CBC, why we listed the other ones, so your MCV, or your mean corpuscular volume, will be less than 80. So you'll have a low MCV, and your RDW will be high, a higher red blood cell distribution of width. So if I was going to say, is this patient just dealing with iron deficiency anemia? First off, it's the most common type. And so when I get my iron studies back, I'm looking, okay, my ferritin is less than 150, my TSAT, let's see where that's at. But sometimes you can even just look at your CBC and say, well, my MCV is low and my RDW is high. Most likely they will have some type of iron deficiency anemia. Then you have anemia that's related to vitamin deficiency, specifically your folate and B12. And on the CBC again, it's kind of the opposite. So you're going to have a high MCV. So if your MCV is greater than 90 and your RDW is greater than 15, I'm thinking, maybe we're not giving the patient enough folate or B vitamins, or maybe they're not taking their multivitamin, the renal multivitamin, because usually the most common causes for a high MCV, meaning it's what we call a macrocytic or big red blood cell anemia, is because they're not getting enough of the B vitamins or folate. Anemia from hemolysis, or chronic kidney disease in general, what you'll see is the MCV will be normal and the RDW will be normal. So you're losing blood just due to chronic kidney disease, mainly due to production. You're not having enough production of red blood cells. And then your anemia from hemolysis, you'll have the MCV and RDW normal as well, but you also have an LDH that'll be elevated with hemolysis. And your peripheral smear, this picture over here to your right, that's what a schistocyte looks like on a peripheral smear. So they're kind of like these really fragments. The one on the far right is kind of more classic, where it's kind of like this essentially half of a red blood cell. It looks like a crescent shape. Doesn't look like your good donut shaped red blood cell. So they'll comment, oh, I see schistocytes. You'll know you have hemolysis. Again, iatrogenic anemia. So anytime I have patients that require frequent blood draws, or they are drawing frequent blood, I keep that into consideration. How frequent do I really need this blood drawn, and which blood am I actually going to am I going to act on? Am I going to act on a daily blood, or really can this patient go like twice a week lab draws, or even once a week, sometimes once a month? Because we overlook it, but a lot of these smaller kids, specifically the infants, will have portacatheters, and it requires a waste of blood before you even get the blood. And then next thing you know, you're drawing 20 cc's of blood. And if you're doing that a few times a week, it doesn't take much to make that patient anemic. Medication induced, if I have a patient that's on immunosuppressive medications for maybe a rheumatologic disorder, I look at those as well, because immunosuppressive medications can kind of slow down the bone marrow's production of red blood cells, causing a suppression of RBC synthesis or formation. And then secondary hyperparathyroidism, as we discussed again, if I have a patient whose bone mineral status is not well controlled, they have a really high PTH, I got to get that under control first to make sure that I'm going to get an effective response from my erythropoietin stimulating agent, or ESA. It's just not going to be as effective. So I got to treat my bone sometimes first before my anemia will work. Then we kind of go down the rabbit holes here. Those are kind of the frontline causes of why these patients are anemic. But then when things aren't making sense and you've checked all those other boxes and all of those don't have a clear etiology to why the patient's anemic, you may think about some infectious causes. A lot of this you'll get from just doing an accurate history on a patient, really diving into it. So if you have, we do see this, it's called parvovirus B19 induced aplastic anemia, mainly meaning the patient has been infected with a parvovirus. Now, this is not the same parvovirus that you'll think about when you have a pet or a dog that goes into the vet for, the parvo. This is a different type. This is more the human specific one. It usually presents again with a microcytic or kind of a small red blood cell on appearance anemia. So you'll have the low MCV again, but sometimes your RDW won't be off or high. So when you're thinking about what we call like a microcytic or low MCV anemia, it may be a parvovirus. You need to check a parvovirus B19 PCR because sometimes it's overlooked and the patients aren't necessarily completely symptomatic with that. You will have infection-associated inflammation as well. So anytime your patients get CLABSIs or central line-associated bloodstream infections, a peritonitis infection, or just sometimes other viral infections, I haven't seen it as much in COVID, but COVID is one of those viruses. Just depends on the level of illness with those other viruses, infections, but what will happen is you have increased inflammation. So you need to consider increasing your ESA dose by about 20 to 25% during the infection period. That just helps the body kind of get an extra bump in production to kind of offset that inflammation to make sure that they don't get anemic because they're not having an effective response from your ESA at the current dose. Sometimes medications, they'll cause that. Specifically, I've seen the ones, as we'll go over, copper deficiency, and they'll get that from excessive zinc intake. I don't have a lot of patients that eat zinc, but sometimes you get this when you have a kid who is sick and grandma's like, hey, I heard take a lot of zinc. Zinc helps to help with your cold or flu or whatever you're dealing with, and they get way too much zinc for the level of their kidney disease, and they'll actually get another microcytic anemia. Again, these are kind of way down the line. They're not first line diagnosis. And even patients who have usually come from binding of copper with the calcium carbonate type binders we used to use. I don't see that as much now that we have Renagel or Renvela. A lot of those binders have kind of prevented the copper deficiency type of anemia. Usually it's excessive zinc intake of some source, nutritional. Aluminum toxicity will cause partial resistance to ESAs. We always check aluminum levels on our end-stage patients. I've had patients get exposed to aluminum toxicity, usually from ingestion, but I've also, we ask them specifically if they have excessive sweating and they're using this like high potent deodorant that's really high in aluminum to prevent sweating. Sometimes they may get a little bit of absorption from that. And then the one that you have to be very careful with, I don't see it used as much, but on our infants, we used to decant formula. I mean, we still decant formula, but what we used to decant that with was sodium polystyrene sulfonate, which is essentially called Kayexalate. So Kayexalate liquid will result in a high, like I think it was up to 300-fold amount of aluminum in the formula from using that preparation. So now, if you're going to use Kayexalate, don't use the liquid preparation to decant formula. Instead, use the powder form because the liquid form has been associated with really high aluminum levels. If you decant with that renal formula with that in the formula, we've tested it before, and there is a study that I can get you on that we did. Angiotensin converting enzymes or ACE inhibitors have also been linked to anemia, although we use it pretty frequently and it's not a common cause. but just it's kind of going through your patient's medication list. As you think about all the causes that could cause anemia, just not forgetting that an ACE inhibitor has been linked to anemia. And then obviously, again, immunosuppressive medications, anything that's suppressing your bone marrow could lead to anemia. Then specifically for those patients that have menstrual cycles, your menstrual cycle, your period, especially those that have heavy flow, can lead to increased red blood cell loss and iron loss specifically. So not forgetting to ask that question, when was your last period? How bad was it? How heavy was the flow? How many pads were you going through? These can be very sensitive conversations, but they're very helpful in determining how much blood and iron they did lose. And maybe they need to go see the OBGYN or their primary care provider and get on, some type of what, people call it always all birth control, but some type of hormone to control and lessen the severity and the flow of their period to prevent them from having so much blood loss. And then the two most common, these are just the ones that I see the most anemia in from a rheumatologic disorder causing kidney disease. So if your patient has systemic lupus erythematosus, I can't ever say that very well, but essentially SLE or lupus nephritis, those patients, due to the inflammation, can have a lot more anemia. And then we call it vasculitis for short. There's different types. You may hear your patient have P-ANCA vasculitis. Again, it's just vasculitis, but that's another inflammatory systemic disorder that, if not well controlled, leads to anemia due to the inflammation throughout the body. And lastly, this is a rare one, but again, I'm giving you all of them. I've only had one patient have this. It's very rare, but it's called it's essentially an epigen antibody or an ESA antibody. Or erythropoietin antibody, however you want to word it. Essentially, it's ESA-induced red blood cell aplasia. They call it PRCA for short. It's a rare hematologic disorder. It's been described back in the 1990s in the literature and some adult studies as well. The problem is it's a severe and progressive normocytic anemia, so no matter what you do, you can give them everything that you're doing it appropriately. You've got them on max doses for what you think you should be on, and nothing's improving. You've eliminated all the other things that we talked about. This could be something because it is a normocytic anemia versus a microcytic or macrocytic anemia. So if you just continue to have this anemia that seems like it's chronic kidney disease or hemolysis or blood loss, this may be one down the road that you suggest to the nephrologist or provider or your team and say, hey, we've kind of eliminated other cause. Do you think they have an ESA kind of induced antibody? Essentially, what happens is these antibodies that they have, they block the interaction between the ESA and its receptor. So they get in the middle of it. So the ESA cannot be effective on the receptor to tell the bone to make more red blood cells. So essentially, you're giving all this ESA to stimulate new red blood cell production, and it's not effective. You have all this dose, and you're not getting the response. It could be this. It's rare, but it could be this if nothing else makes sense. The problem with this is the patients become red blood cell transfusion dependent. That's the only way to really fix it. And that just leads to antibody formation. So how do we treat anemia? So there's different approaches. Make sure I move this out of the way so you can see here. Oops. Go away. So the first one, though, is erythropoietin alpha. It's also known as Epigen, Procrit, or Retacrit. The dosing, it varies in the literature, but somewhere around 150 units per kilo.
Tyson.
Yeah.
Oh, never mind. I thought the Teams thing was still there, but it just popped
No,
away.
I try to make it go away.
Yeah.
So erythropoietin alpha, Epigen, Procrit, and Retacrit. The dosing is somewhere around 150 units per kilogram per week. And how I say to start it is usually somewhere around 50 units per kilogram per dose. And depending whether you're giving it IV or whether you're giving it sub-Q, will make a big determination on the frequency. So if you're giving subcutaneous injections or sub-Q, usually it's going to be a twice a week for EPO. Our patients most commonly do like a Monday, Thursday, or Tuesday, Saturday. I don't really care. One of those type of frequencies usually works. And I'll start them somewhere on 50 units per kilo per dose. And then it can get up to around 150 units per kilogram per week. So I think the max I've seen is somewhere around 300 units per kilogram per dose, which is excessive, and I'm not sure how effective it really is. But if you need a starting dose, pick somewhere around 150 units per kilogram per week, divide it by 2 if they're doing sub-Q, divide it by 3 if they're doing IV, and you should be okay. Expect to repeat your H&H or your hemoglobin and hematocrit in approximately 2 weeks after the dose change. You have to wait that long to actually see a response, a reflection of the dose that you made. Checking it any sooner, you probably won't get a true reflection of where you're at on that current dose. And then you need to watch for hypertension. So if your patient starts developing hypertension as you're increasing your ESA, you may want to look at your hemoglobin rate of rise. So as you're trending your hemoglobins, if your hemoglobin is increasing more than 0.5 grams per week, then you may consider backing it down because it can lead to hypertension. It does have kind of a black box warning for stroke and things like that, and cardiovascular complications using really high doses or putting the patient having that increased rate of rise too fast. So usually they're fine if they're 0.5 grams or less per week. Anything over that, you can cause the patient risk for, hypertension, because what's happening is their blood's being crowded with so much hematocrit or red blood cells too fast, and that leads to the hypertension. Darbepoetin alpha, also known as Aranesp, it came along. It was nice because it wasn't you didn't have to give as frequent of injections. So for infants, children's, and adolescents, you're dosing less than 18 is going to be somewhere between 0.42 to 0.45, depending on which reference you're reading, micrograms per kilogram, and it's usually dosed once weekly. Adolescents greater than 18, the standard is usually 0.45 mics per kilogram once weekly, somewhere around, if you need to space it out, 0.75 mics per kilogram every 2 weeks. So you kind of have options on decreasing the frequency, so they're not getting twice a week injections. You can cut it down using Aranesp to once a week, and sometimes in the older population you can even get by with doing it every 2 weeks. That's mainly for compliance reasons, because doing twice a week injections is not fun, and your adherence may go up if you use Aranesp because they only have to do it once a week or sometimes every 2 weeks. I will tell you, I've heard from many patients, if you look at which one burns the most when you give a shot, it would be, per patient complaint that I've heard, the Aranesp burns more than the Epogen and the Mircera. So you may think about compliance with this if your patients have a lot of fear with needles or injection pain, because Aranesp does sting a little bit more when you give that injection. And I think it's just due to the preservative that they use in it to keep the half-life longer. Then you got this new one out here. It's kind of a hot off the press one that adults have been using it in hemodialysis units, I know. In pediatrics, some units have been kind of playing around with Mircera. It's a long name. It's like methoxypolyethylene glycol epoetin beta. So long name, we just call it Mircera for short. There are still some, I think, phase 3 trials going on. I know there's like a Clara phase 2 that was done. So if you look in the literature for Mircera, you're going to see some of those trials that we've been doing in pediatrics. The dosing is, what's nice about Mircera is that it's given every 4 weeks. So, and you don't have to give but like a monthly injection, which is nice. And I've also heard that essentially the sting or the burn, like Aranesp has, that patients who have had, they're really needle phobic. They don't like injections because every time they think they're going to get an injection, it's going to hurt. I've had really good tolerance with Mircera in that regards. You do need to check your hemoglobin right before your next dose, and it needs to be pretty close to it because of how you dose it. You don't have the ability then, like if you want to make a change within 4 weeks to make another change, you can't give another dose. It has such a long half-life. I don't recommend using Mircera for patients that you're struggling with anemia to keep them in range. But it's for those patients that, for a while now, they've been doing pretty good. Their hemoglobin's staying between 10 to 12, and they're just struggling with injections, whether it be compliance, trying to remember all of them, or they don't like the feeling of the stinging and the burning from the injection. Mircera has been a good option for those patients. And I've actually had them get spaced out to even 5 to 6 weeks of injections because it works so well. The problem is the lowest dose is 50 micrograms. So if you need to decrease the dose further, you can't. So what we have done is just decrease the frequency down to It's supposed to be decrease, not just increase the frequency, but decrease the frequency to 5 weeks instead of 4. So just pushing it out an additional week is essentially how you'll decrease the dose, if you will, because you don't have the option to do it with the vial. And Mircera, I've had a lot of people say, well, how do you get this for peritoneal dialysis patients? Because a lot of insurance fight it. I still fight them to this day. Sometimes how we get around it is we will give them the injection if they're in your clinic. How it goes to the insurance is a little bit different. I'm not trying to tell you how to get around insurance, but it's a different way to get them to pay for it. We've given it in the clinic during their monthly end-stage kidney disease clinic visit. We've been able to give them that medication that way versus trying to get it as an outpatient prescription. And it helps us because we time it. We may get labs like right at the day of the visit or right before the visit that they're going to come. So I have that hemoglobin I need right before the next dose to know, do I need to go up or down on the dose? And then we can give the dose in clinic. But as far as getting it approved as a prescription from insurance as an outpatient use, even I haven't had good luck with it because there's not a lot of literature out yet. It will be coming for insurances to agree to approve for it. The thing with ESAs, though, on any of them, there is a black box warning. Don't forget this. It does have an increased risk death and serious cardiovascular complication when administered to get a target hemoglobin greater than 12. This came out many years ago, but essentially, if your patient is greater than 12, you got to be decreasing or holding. Sometimes if it's too high, you got to be really backing down on your ESA so that you don't lead to cardiovascular death. Because again, our patients, specifically those with end stage, need to stay somewhere between 10 to 12, not up in the 13s to 14s. So Mircera dosing, the one I pulled here on the table on the left is actually from the study, but I love it because the yellow is just the patient. I could not find the table without the yellow highlight. It doesn't mean anything, just FYI, but I was trying to get this table that I didn't have a yellow highlight. The yellow highlight was just the dose that we use for our patient, going off the study kind of data. But what's nice is you can kind of see your previous weekly EPO-eaten alpha or your epogen beta, so your EPO or your AirNesp dose in units per week. And you can see here your ranges and then what the equivalent Mircera dose would be for your patient. I will let you know that this 30 dose here on this table is not available that I know of. This was a study drug that they used, so disregard that kind of top one because I haven't been able to give the 30. Usually it's start looking at the doses of 50. That's the lowest one I've been able to get. So these are your doses according to your epogen or your AirNesp dosing in units per week. Over here to the right is actually from the package insert from Mircera. There is your link down low if you need to read about it. They will say give for the EPO-eaten alpha 4 times the previous weekly EPO eaten alpha dose in units divided by 125. So you got the math there. Same thing for the darbo-eaten alpha. You got 4 times previous weekly dose of the AirNesp in micrograms divided by 0.55. So if you need a conversion, this is going to be where you go to kind of convert what you might give the patient for Mircera dose. Now, there is a disclaimer on the package insert until more of these studies come out. So in pediatric patients, you can only administer Mircera only intravenously, is what the package insert will say. No subcutaneous injections in pediatrics. A lot of that's just because the data isn't there for the FDA and all those guys above to approve it in subcutaneous, only intravenous. So just keep that in mind if you're considering Mircera, what the package insert, what the rules are on it before you start giving it. Don't want to bash it. It's a great drug, though. Probably be the way of the future for some of these patients. So again, with anemia management, just a simple boom. Here's essentially how we go on a daily basis about how we treat anemia management for these kids. So if your hemoglobin is less than 10 and they're on ESA, just increase your dose by 20-25%. If your hemoglobin is greater than 12, I would start decreasing the dose by 20-25%. So it's easy, just a 20-25% increase or decrease depending whether you're greater than 10 or less than 12 as a start. And then just repeat your H&H approximately, I would say 2 weeks after the dose, but on timing wise, if it's 10 to 14 days, it's probably reflective of your current dose that you just increased. Now, if the patient's level is greater than 13, you kind of have this dilemma. So you should not hold a dose of the ESA unless their hemoglobin is greater than 13 is kind of the standard rule because you're pushing in risk of them being too high. However, you may just consider lowering the dose, because what happens is when I've seen the stopping and the starting and the stopping and the starting in our area here, you get on what's called a roller coaster effect because you're messing with the bone marrow too much. You're telling it produce, 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 and then you essentially shut it off, and then it falls, and it takes a little bit while to play catch up and get your bone marrow to kind of kick back in again, and then you're ramping the dose back up, and now they're too high, and then you're bailing again, and they're crashing, and it takes a while again, and you're going back up. So you get on this roller coaster effect. If you've decreased doses and they're still greater than 13 and you don't really have room to go, yeah, hold it. But what we've seen is if you've decreased, what you should start doing is just start decreasing it by 25% and keep checking labs maybe weekly. We check them weekly just to make sure that the hemoglobin isn't continuing to escalate up into the 14s, because at that point you would have to hold it. But the point here is the stopping, the starting is not the answer to keep a stable hemoglobin level. Considering really just decreasing that dose if they're 13, greater than 13 or at 13 by maybe 25%, and just repeating your labs a little more frequent to watch that level come down into a safe range. If you need to hold it though, and at the point you're going to restart it, so let's say they're 13 and a half and you decided to hold it, and now they're coming down and they're essentially like 12.8, 12.8. As they closer they get to 12, the best thing to do, restart it when they get close to 12, but at 25% less of the dose you had them on before. So if they were at, let's say 1,000 units and their hemoglobin's greater than 13 and you decreased it, or you put it on hold and you're watching it fall, go back to 750. So a 25% kind of decrease in that dose as your resuming dose. If the hemoglobin increases too rapid again, it's going to lead to hypertension, possibly stroke. So considering decreasing to target rise somewhere around 0.25 grams per week, nothing greater than 0.5, but if they're at 0.5, you may sit tight. So just watch your rate of rise. If a patient has your, hyperparathyroidism, elevated PTH, treat it, or they're not going to be effective. And in some patients, they also later on with transplant, I've seen them, especially those who may be early on transplant and we're drawing a lot of frequent labs to manage their kidney transplant. They may need to be on an ESA for a short period of time until we back off on lab frequency, or those patients that have had a kidney transplant for a long time and their kidney function due to transplant nephropathy, just chronic, you can't fix it, the kidney function is declining. And what will happen over time is they'll start getting into CKD again. Those patients may need another ESA. So before we get to the question and answers, I kind of want to go you through some case examples and those were just the highlights of anemia. We have other presentations that dive into iron anemia and all the little things and niches about it and how it's transported. And I can give those talks if you guys want. But for this one, I just want to keep it very brief and kind of go over how do they get it? How do we diagnose it? What's the common way we treat it? And then give you some examples. So for case example 1, I'm sitting here looking and I got a 15-year-old female with chronic kidney disease, grade 4, so CKD4, secondary to renal dysplasia. Just some quick labs that we drew. The patient's coming in for a visit. You look, their hemoglobin is 9.2, hematocrit is 27.6, MCV 80, and RDW 17. And I specifically did not give you the normal ranges on the side over there because I want you to kind of get used to the normal ranges. And your BMP is 140 sodium, chloride 99, K 4.2, calcium 9.2, and obviously CO2. So unremarkable. So 1 second, people keep trying to call me and I'm trying to block this here. So as you can see, sorry for that, your BMP is stable. There's nothing there. Okay, we're good. Your phosphorus for a 15-year-old, 6.4, that's pretty normal. But when you look at your CBC, just initial thoughts that, what do I think initially? Well, okay, I know the age of the patient. I know they have what stage of chronic kidney disease, and I know why they have kidney disease. Obviously, they're anemic. Their MCV is low, and their RDW is high. So if you remember previously, as I think about what may be causing this patient's anemia? I have to think, okay, well, they have chronic kidney disease, grade 4, so maybe it's through, erythropoietin's not being stimulated because they have chronic kidney disease. So the bone marrow is not making more red blood cells. And then you have, um, it's a 15-year-old female, so you have to ask again, are you having a period? When's your last period? How heavy are your flows? Going over those details because maybe the patient is losing a lot of blood or iron from their periods. 15-year-olds also struggle with compliance, so looking through their meds to see, it's not to stereotype them, it's just the truth. The teenagers like to be independent, and sometimes that they struggle with medication adherence. So when I think about initially, I think, okay, I got a 15-year-old. There's a couple things I need to probably add on to this to make sense. When you look at the CBC initially, I would think iron deficiency anemia. They're not severely anemic, they're just anemic enough, and their MCV is low and their RDB is high, so most likely it's an iron deficiency type anemia. So I would add on some iron studies, your ferritin and your iron and total iron binding capacity. I may check reticulocyte count just to see how well their bone marrow is even making red blood cells. And then going through the medication list, seeing if they're on a multivitamin, see if they're on an oral supplement, see if they're on anything that would bind to iron, kind of going through their med list again. Renal dysplasia in itself is not usually a form of kidney disease that would cause anemia in itself as an underlying diagnosis. So this is most likely due to either the kidney disease, a period, some type of iron loss. Maybe the patient has decreased appetite because of their chronic kidney disease. So you're thinking about dietary restrictions, all those things we talked about ahead of time. That's kind of how just getting this basic history and labs, just the first things I'm thinking to kind of help you think, see what from a provider's perspective, how I would kind of just start thinking about this patient initially. Then you have a case example number 2. So you have an 18-month-old with end-stage kidney disease or ESKD, secondary to posterior urethral valves, very common in this population, who is on chronic peritoneal dialysis. Labs, we draw more than these, but just to keep it simple, the CBC shows hemoglobin 8.8, hematocrit is 26.4, MCV is 106, RDW is 18. So your BMP, unremarkable really for an infant. Calcium's a little low. That's what I see on exam. Otherwise, not terrible. You might say potassium's high, but it's an 18-month-old. I don't get too scared with the 5. And then iron studies, we actually got those on this one because it's end-stage patient. So your ferritin's 115. And then there's an iron and TIBC, but a lot of that's just to do the math. Remember, iron divided by TIBC gives you your TSAT, which is 25%. So not bad there. It's greater than 20%. So what do I think initially? Well, I know this patient obviously has end-stage kidney disease. It's due to posterior urethral valves, which is not essentially like a rheumatologic disorder. So very common, not a big deal. That's not causing my kidney problem necessarily, or my anemia problem most likely. But they're on peritoneal dialysis. So I had to think about, okay, well, what all is required for peritoneal dialysis in this population. So let's go back to the labs. Well, they're pretty anemic. Okay. Again, do I have them on the right amount of ESA dose? Do I have them on enough? Usually the infants, just so you know, will require a higher dose of ESA than the adolescent or adult. So you might be a little bit like, wow, they're on a bunch of EPO. That they need that to keep a stable hemoglobin level. Their MCV is high at 106, so kind of upper limits around 100. All right, I got a high MCV and RDW is high as well. It's greater than 15. So I'm thinking, do I have this patient on a renal multivitamin? Do I have them on what's called Nephronex? It's the liquid version, if you will, of the renal multivitamin that we give a lot of our infants. So did I forget to prescribe that? Do I have them on enough for his age? Because there's dosing adjustments as they grow for the renal multivitamin. The labs, I'm looking, okay, my calcium's low. Whoa, what else am I missing? Oh, I don't have a PTH level. So I don't have my bone studies on this kid. So I need to make sure I have my bone studies. What that means is I need to add on a phosphorus and a PTH to kind of get the whole picture. Because most likely if their calcium's low, their PTH is going to be high. So maybe I'm dealing with some secondary hyperparathyroidism. Maybe it's really high PTH is blocking my ESA effectiveness. Okay, and then when I look at the iron studies, well, their ferritin's it's a little bit low. It's less than 150, but otherwise their TSAT's fine. And then I got to think about again the meds. Are they on calcium carbonate? A lot of them are for supplementation. how do I schedule? Because you want your calcium carbonate scheduled approximately 1 to 2 hours away from your iron dose or other meds, because it is a magnet. Calcium carbonate binds to essentially almost everything. So separate your calcium carbonate out by 1 to 2 hours. So I got to make sure I look at their med list. Other than that, you can draw the same labs we talked about earlier, but that'd be essentially how I go about it. Renal multivitamin, looking at secondary hyperparathyroidism, looking at their ESA dose, making sure I have them on enough iron. What you want for iron in this population is somewhere between 3 to 6 per kilo, milligrams per kilogram per day. And then case example number 3 is an 8-month-old with end-stage kidney disease, again, secondary to congenital nephrotic syndrome, who's on hemodialysis 6 days a week. Well, that right off the bat is okay. So got a CBC, very anemic. Oh, great. MCV is normal and the RDW is 13. So those are normal ranges. Okay, so I'm dealing with not microcytic, I'm not dealing with macrocytic anemia. I'm just dealing with essentially anemia from blood loss or anemia from chronic kidney disease. BNP essentially unremarkable. That's stable essentially for a kid if you look at those labs. And then the ferritin, it's pretty good. And then the TSAT, I'm doing really good there too. So got them on enough iron somehow. And it's most likely because the patient's getting it IV with their treatments. So what do I think initially? Well, it's an 8-month-old. So they don't have a lot of blood in their body anyways. Then I'm going to put them on hemodialysis 6 days a week. So essentially what I'm doing is I'm causing the patient to be anemic because I have them on such a frequent schedule of hemodialysis, because that's what they need to keep up with their fluids. A lot of them are on renal formula, which equals volume, which equals more days, because they can't go with days off without dialysis, or they get hypervolemic or fluid overloaded. So just the frequency of dialysis itself on that kid will cause iatrogenic anemia, or just I can't give all the blood back every treatment. And they're not losing iron, but I just can't give them back the amount of blood each treatment, and their body can't keep up producing enough. So this patient's headed towards a blood transfusion. And this is very common. I just ran into this where I had a kid, he's on frequent hemodialysis, and he's already gotten 2 blood transfusions despite our best efforts, because I can't keep up with medications and get his body to produce enough blood to keep up from all the blood loss every day. So essentially on that, you need to compact and kind of change the concentration of the formula, see if you can condense the volume down to decrease the frequency down of dialysis. That will help your anemia if possible. Not always an option though, because they don't tolerate it. And then just making sure that I haven't missed anything, they don't have just making sure I have them on a good renal multivitamin dose and all of those things. But this kid is essentially having anemia. I bet money, because I've experienced it, is because of blood loss due to the frequency of hemodialysis. So those are kind of some just basic case examples of how I think about when I see anemia in these kids, and how diverse, how many different routes it can be from, and kind of breaking it down. If you go through this and kind of use this tool from this webinar of kind of just how to break down anemia from what doesn't cause it to what labs have we gotten okay, and what meds are they on, okay, check. And you can kind of almost formulate your own little plan amongst yourself, looking at your patient's anemia on one page. So with that, I thank you for your attention. I know we're running out of time, but I do wonder if there's some questions. Like I said, again, if you want more webinars on kind of deeper dives into certain types of anemia, we can obviously do those, but let me know. Just post on the forum, hey, I'd like to hear more about dive into iron deficiency anemia. I want to know the ins and outs. I want to know the ins and outs about the weird stuff that causes anemia, where these vitamins or carnitine supplements that we use. But obviously this lecture could go along. So any questions? I'll wait for you, Celeste, to see.
Yeah, I'm not seeing any questions right now.
So what I want to share with you lastly, though, these references. So these are the ones I go to a lot. These are excellent articles for pediatric anemia. Obviously the one that the easiest one to read, I'm going to tell you right now, is that it's an older article. It still stays true to this day, but it's the optimal care of the infant, child, and adolescent on dialysis. It also is true for the patients who have chronic kidney disease. It covers essentially A to Z in a very easy meat and potatoes way of what you need to know. Then if you want to get a little more advanced, you can kind of read the other articles, because it does a deeper dive into the anemia in this population. And then the Mircera dosing reference information is down there as well, if you want to go to their website and read more about it. But if there's no other questions, I thank you for your time. Let me know, message me on the forum, and we'll do some more webinars.